I hope that no. So we have medical surgeon, radiation oncologist, medical oncologist, and radiation oncologist. So largely the field of prostate cancer and one more medical. Now that balances. One surgeon is enough for all. Yeah. So there are 30 minutes, 8 abstracts. I am going to be very crisp. I am not going to show all those curves because most of the speakers have eluded the data. And what you have done, the organizers, you have already given the expert comment, so we know the answer, right? We know the answer. Dr. Kumar Prabhash has done a fantastic job. So we are going to discuss what we actually do in our clinics. So we'll start with the case quickly. This young male, 58-year-old, with a family history of cancers, with well-controlled comorbidities, presented with no urinary symptoms, and the PSA was 11, biopsy was Gleason's 4+3, group grade 3, and the lesion was a little bit touching with the capsule, extraprostatic extension. So what all the investigations when such patients comes to you? Because we have been practicing for more than, say, 4 decades, where the investigations have been improving. And those cases which have been labeled as a locally advanced, now if you add a PSMA, suddenly you upgrade those patients. But those patients who have been operated years back come for follow-up, then we really have to ask ourselves whether we are over-treating them by over-investigating them. So what are the investigations you judiciously use for the patients in prostate cancer?
So in this patient, I would like to jump directly for the gallium PSMA PET scan instead of doing conventional. Apart from the, when I do PSMA PET scan, I do DRE, and if it's because in my mind, I may treat him surgically. If it is resectable, then PSMA PET will answer my all staging purpose. The purpose will be served. Or else bone scan with MRI with the CT.
Okay.
MP MRI and the CT, or MRI pelvis, that will tell us the lymph nodes.
Okay. Kulkarni sir, so why I mentioned 4 decades, because within the span we have senior surgeons sitting in the audience. And Mike, please, there.
Well, thank you, Bharat. I agreed that we started in 77 and now 46 years. Of course, that time we had only bone scan. We didn't have anything. Then came in other scans which are F18 and other things. In between, we have been believing in whole body MRI was another good way for bone metastasis. Having said that, PSMA has revolutionized completely, even in Europe for that matter. That non-metastatic CRPC is going down because they were all actually metastatic CRPC, if you recollect that. So I think PSMA scan is very much, although of course the cost is a little issue, but I think in the long run, 25,000 or 20,000 is really not much. So I think we shouldn't make a cost as an issue rather than, the only thing which we are talking about a PSMA PET scan is today even to diagnose the primary disease.
No, but
that's going to come up. That's going to come up. But I think PSMA is the right way.
So you agree that PSMA. So Dr. Kumar Prabhash has rightly mentioned it's a systemic disease. You can't do without the systemic therapies. So that is why PSMA is very, very important. Now burden of disease we discuss as per we'll come to that criteria because there are only 30 minutes and otherwise it will go on surgery only. I have to talk about CAR-T. So this was the PSMA scan, no? Don't ask me too many questions. We have to finish.
It's very
so
clear.
To the surgeon, would you like to operate this case? Only one lesion. That is because
first paper which was discussed, surgery in the oligometastasis. My take on the surgery, if it is a T2 disease in the PSMA scan, I don't know what is the report exactly and what is the examination. Solitary mets, and what about the primary disease? But in the examination, if I am okay with the plane,
operable. Primary is operable.
or the planes with the rectum are okay, I am not very much concerned of the neurovascular bundle involvement, and the disease is not going into the bladder, and I can safely, resect the apex without, because why I am talking about the apex, because the continence fully depend upon how I dissect that. So if these things are okay, then I am very much comfortable in operating patient. If I have robot, I have no experience of the open and the laparoscopy. So I would like to go with the surgery in this patient.
So very important point you highlighted. If your surgery is not going to add the comorbidities in terms of incontinence, such cases can be taken on the table. Robotic versus no robotic, I will want a quick answer from you.
Should not discuss, because
Should not be
majority
discussed.
of
Okay,
the
got
surgeon,
it.
they are doing
Yes,
robot.
so got it. So there are certain cases we really know bring to the multidisciplinary team discussion, and such cases should be discussed in a multidisciplinary team where all of us are sitting, including the systemic therapy person, even the radio imaging persons can discuss about these scans. One odd case is sometimes we end up in saying non-metastatic disease. The scan must be discussed in detail whenever you see some, when you don't expect to have metastasis and you see something, the scan needs to be discussed.
Primary should be treated if
Yes.
we are not harming in the sense
Yes,
of no
very
rectal injury, no incontinence for a long time,
Very
maybe
important
patient.
point.
So
that is-
we should go for that.
Yeah, this is a very important point. If we are not harming, then this modality needs to be discussed. Now, surgery versus RT. So this abstract is actually for another purpose. So there are phase 3 trials where the RT in oligometastatic setting has been discussed, Stampede and one more trial, where it has actually shown benefits. So when we have a radiation modality of treatment in this setting, whether we should prefer surgery or radiation, to the radiation oncologist. First you and then Dr. Parneet can.
Thank you. I would like to ask the surgeon, you didn't ask for an MRI. You said you were not going to harm rectum, so I'll operate.
Yeah.
But if you have extra prostatic extension, the margin comes positive, again you'll send it to me. That's
No worries.
Again, after that, if the small met is there, again you will send it back to me. So why operate?
No, this is the literature. We are discussing the science.
No, you said you will do.
Yes, I will do, because the purpose of operating on primary, be it a radiotherapy or the surgery, is can we safely treat the primary? So if I can keep patient continent, if I am avoiding the rectal injury, and in the robotic second day patient goes home, so I would like to operate on patient, and so that I have detailed the histopathology in my hand, and further treatment, yes, we can go as per the literature.
So we will not go into that debate.
Yes,
So
that
I
is
have a really
endless
short-
debate.
So you raised
Yes, sir.
that-
No, I raised the debate, but sorry to that. So what we want, I said the feasibility trial. So what we are discussing is the feasibility.
It is
And then,
feasible. See,
yes,
it is
agree.
feasible for me to treat.
Yes. Yeah, so there is a data that, so I am asking
Why
you.
I should do or
Yes,
why
yes,
he
yes.
should do, we should discuss.
So
Also,
I
both-
said it should be brought to the MDT. If everyone agrees, then we'll send the
MDT is
patient to him.
going on
I said
here.
I will not send the patient to him.
MDT is
Yeah.
going on
So
here.
you say your point, you don't ask him why you
I
operate.
think with radiation, what helps is we can treat both the lesions in the same setting, and then we can go for ADT further.
Yes. See, why I'm discussing this, when we do such MDTs, I think patients should be also part of this MDT. They should know what are the pros and cons.
Exactly.
I'm not saying this, yes, exactly. So we have a data. This is the another modality. And
So, okay, let me say, I don't know whether you will come to the final question. Like if I do
yes,
only radiation, as the other radiation oncologist said, what will be your 10-year survival data and OS or PFS, radiological, biochemical progression-free survival, and what will be mine? We will come to that or no?
Yeah, we may discuss, but I don't.
no, there is no phase 3 data, level 1 evidence for the surgery, definitely. There is no phase. Based on why I'm discussing, there are patients, anecdotally, we have been seeing those who are surviving.
What do you want from me? You
No,
tell me.
so how would you treat? Whether treat with systemic
I will
therapy
do
first,
radiation,
upfront radiation, or
Of
you?
course, I will do, it is
Fair
a
enough.
favorable intermediate. You
So this
said
is the
because
oligometastatic
it's a
single
bone
lesion.
met,
Single
It
lesion,
is
high risk
it's a
disease.
One lesion. One lesion, he showed.
Extra
So,
prosthetic extension.
so the question is, would you like to add something upfront, or you would straight with the RT?
It is metastatic. I would like to
Yes,
use
yes.
ADT.
Perfect.
Okay, at least 1 year.
1
And-
year.
Yeah, and I would do radical radiation therapy.
Okay. Anybody wants to differ? Vivek,
Yeah.
and then
So
Dr.
I
Parneet.
think the debate is coming nowadays because we are just extrapolating our facts, but we have to understand this is a metastatic disease and this is a systemic disease. We already have metastasis. Yes, it is oligometastasis, but because it's a systemic disease, systemic therapy is most important. And I would want to, this is a is a high risk patient, but it probably, because it is oligometastatic, it falls within the purview of a good type of a patient. Because the other parameters are within the low risk. So if I classify this patient as per a metastatic hormone sensitive prostate cancer, This is a low risk type of a metastatic patient.
Low risk, low burden disease.
Low risk, low volume. I mean, for me, the risk stratification goes beyond volume of the disease. You have to look at other factors also. Yeah, so for this patient, I would want to start on ADT plus one of the novel androgen receptor antagonist, maybe enzalutamide. And as per the Stampede and the Latitude trial, we already have evidence that this patient can be treated with.
After how many months? After how many months? Because he said 1 year.
So I think that really depends upon the response, but we will do a 3-monthly MRI and maybe a 6-monthly CT or a PSMA and then go for.
So you would like to see the
IMR.
speed of depth of response and then you would like
Correct,
to choose.
correct. I mean, that really depends upon an MDT discussion
Dr. Parmeet
and
wants to say
probably
something.
I will discuss with my radiation oncologist what is the best time
So he wants to say
depending
something.
upon the response.
I also agree with him. I think we should start with systemic therapy and then see the response.
You would like to assess the response and then we'll decide the time.
Then RT.
Ajay?
Yes, sir. I also agree with the Vivek, sir.
So basically-
response duration will be around 3 to 6 months.
Yes, so basically everybody wants to start with the systemic therapy, that is ADT, and then wants to see the response whenever, up to 1 year, maybe 6 months, 1 year. I'm coming to that.
What response?
Okay. What response? Vivek, you started. What response? Biochemical, radiological, because Vamshi clearly mentioned, most of the time we end up in, following with the biochemical.
So I just want to ask my radiation oncologist why he is
See, Vivek,
waiting
you
for 1
answer.
year. What response?
No, I will give.
So you said you want to wait for 1 year. I want to ask, so why are you waiting for 1 year? For what?
No, he's mistaken me. I am not saying wait for 1 year. I said treat locally. If you want to give as a neoadjuvant,
So-
it's okay.
Correct, sir. So we can go after 3 months also. We can go after 6
So
months
Vivek,
also.
but
what
Dr.
response
Vamshi
time?
mentioned in his center
One-
they are starting after 2 weeks only of AD.
Vivek, so you are saying 3 months also we can be treated. So everybody agrees that at the 3 months also we can treat if the depth of response. So main idea here is that we can't do without ADT, and that is what the next abstract is, where in oligometastatic setting they tried the feasibility of not giving ADT. I think we are not there to avoid ADT. It's good thing that we have an oral agent where they tried for 6 months. Something which we have tried in the past is intermittent ADT, where you can, but again, compliance of the patient is very, very important. Patient has to come.
Those
So you
data
don't-
only for recurrence.
Oh, yeah. So what
Sir,
I'm
what-
thinking,
what
that has
actually-
been tried before. 6 months in a metastatic setting is not acceptable thing. One has to be on the ADT in a metastatic setting.
For upfront, we don't have.
No, for this.
Sir, actually what time gives us is a test of time to test the biology of the disease as well as the metastatic site to see whether it is actually an aggressive disease which is progressing or not. And 5 to 10% of patients we are going to get such kind of an aggressive disease.
Vivek, I differ with the other Vivek that it will not progress on ADT. This small disease, we've never seen progression upfront,
So-
castration sensitive.
So that is where our surgeons also say these patients are going to live for 10, 15 years. Some of them. We don't know the biomarker, and that is why not to operate. So we'll not go into that debate. So that is why they provide that modality also. But we don't have a level 1 evidence. I don't know. I have to say the surgery in oligometastatic setting. So you have asked the question to him, but I am not answering. Biology of the disease, we yet not there to know what is biomarker. What biomarker can tell us that this patient is going to live longer. And surprisingly, we have patients who have been operated in the past and they do well. The modality was not there to detect them in the, they were the oligometastatic disease. But yes, I'm not here, to support the surgery. But the main thing is, this is a disease where discussion of all the modalities together is very, very important, including the patient knowing the pros and cons of the modalities. So we'll not go into details of this. So I have already discussed this. These are the trials. So in metastatic setting, the space is getting crowded. With the French group IGR data of 3 modalities, chemo, abiraterone, steroids, and now you also have questions, okay. For the surgeons,
For the medical oncologist.
for the medical oncologists.
So you said you will give novel hormone agent, I agree with it, but will it be treated indefinitely or you would like to restrict ABI at 2 years for this patient? Only one bone met and prostate primary. So
In
it's
this scenario-
purely an oligo.
Yeah,
So the
ADT
second abstract,
So,
maybe that oral.
looking at
GR.
oligometastatic
ADT
curative setting, I think 3 years
Let me
time.
complete the question. ADT indefinite, I mean the GNRH analogs.
I think, sir, because it is the oligometastatic disease and if we have given definitive RT,
Yes, we have
and
given
if everything
definitive
is in
RT.
control, then I would want to stop at 2 to 3 years.
Both ADT and ABI at 2 years.
Yeah, I would not want to use abiraterone. I would use rather an enzalutamide or an apalutamide or a darolutamide.
Enza or AB, whatever.
Yeah.
And any novel hormone therapy plus ADT at 2 years. You agree?
Yes, sir.
So this trial where they looked at the placebo versus 6 months of GnRH oral antagonist, and after 6 months we maybe getting the data. So he said 3 years. There is no data for 3 years also for oligometastatic. Metastatic, once metastatic is always metastatic. But yes, on a individual case basis, you can discuss based on the toxicities of ADTs.
I think you can extrapolate from the high risk prostate what they are doing is ADT plus
Exactly.
ABI for
So
2 years.
extrapolation from high risk,
High risk non-metastatic prostate.
non-metastatic. I think in our clinic, as the debate goes for surgery also, we do take the decision based on the patient's tolerance to these therapies. And if the patient is doing good, we really fear to stop that particular therapy because nobody wants to jump to again from a controlled disease to a metastatic setting. But yes, as he said, you can take a decision, individual decision. So as this space is getting crowded. We have chemotherapy, newer androgen steroid, now enzalutamide, and then now darolutamide. Somebody said to take the names is very difficult. Medical oncologists can take the name, but the CAR-T names are very difficult. Sir wants to say something. The CAR-T cells are now again the next level of difficulty to pronounce them.
So here the only comment is that doesn't mean individually I totally agree. We do many more things, but when we say that we're stopping it, it is a bit of a de-escalation. See, so the moment you say de-escalation, remember when we have done it. When we do it in pediatric ALL, we do it when we have 10 years survival of 90%. In HPV oropharynx, and we treat a lot of them with radiotherapy, people did de-escalation. We had egg on our face. Cetuximab versus cisplatin, 10% lesser survival. Here we have a metastatic disease. That doesn't mean I say we don't do de-escalation. We do de-escalation metastatic disease also when toxicity is high and we are not certain about benefit. So there is a bit of an uncertainty about benefit, but I haven't heard in last 20 years anyone having courage to stop it. So we are thinking of stopping ADT. Only idea is that be careful. It is a bit of a de-escalation in that sense.
So in prostate cancer,
I totally agree, sir. But oligometastatic disease we have treated with curative intent in many other settings. Now even in lung cancer also we have treated oligometastatic disease. In breast cancer also we do. And after a curative intent treatment has been given, we do want to stop treatment and not give any maintenance. For example, in oligometastatic HER2 positive breast cancer, we do stop at 1 year of trastuzumab maintenance. We don't continue it if curative intent treatment is given. So if a curative intent radiotherapy is given to both the oligometastatic site as well as the primary, then I think it does make a case for withdrawing it and keeping on a close PSA surveillance.
Vivek, we had a trial where Stampede, they have given ADT. So if there is a stoppage of ADT at 3 years in that particular trial, my question to you, it was continuous. So in a trial, it has not shown. So as sir rightly said, de-escalation has to be tried. I think we are in an era.
Bharat, let me. It's a very good comment. So let us take it that high-risk prostate cancer localized is better than oligometastatic disease. I hope here we are not arguing. We can have an argument, but that will be a different discussion.
Kumar, I'll tell you.
In high risk, give me a second, Vivek. So if we think about that, high risk prostate cancer requires intensification with docetaxel and abiraterone as per a Stampede. We are saying that in oligometastatic disease, we want to de-escalate. I'm not saying don't do it. Case to case basis, be careful. You have multiple situations where there has been a problem when you have done de-escalation. I gave you one good example because I treat head and neck cancer. I had never thought cetuximab in HPV positive patient where 5-year survival is 80% and beyond, you change one drug to other and that both drug has a randomized trial that they work. There was a 10% decrease in survival in localized disease. Be careful in metastatic disease. That's what I'm conveying. That doesn't mean to say that you may not do case-to-case basis.
Sir, initially when RT started for oligometastatic prostate cancer, the endpoint was delay of ADT. So they did not add ADT upfront when we started giving RT for oligometastatic prostate cancer. But in practice, even I am scared not to add ADT. So we add ADT to each and every metastatic patient, be it oligometastatic also. Now, arguing on the duration, I think, yes. So we did not add ADT to any patient. We said that we are giving RT for oligometastatic disease because we want to delay initiation of ADT. And only when the patient progressed, we started ADT. So but I have not done that in practice.
I got it. So this is a very fair comment. So what happens is, and I made a comment in the context of lung, when RT was getting developed for oligometastatic disease, systemic therapy was simultaneously being developed. So problem for you is, or for us is, that science doesn't have a linear development. You have a parallel development happening, and that's why what you are saying in pragmatic way, that this is what you do. Why you do? Because you have seen in metastatic disease, when you give ADT, what happens? RT doesn't give that kind of relief to the patient.
It's a local therapy.
So please, I'm sure, please go ahead. One should do it. But to remove ADT out of it, in today's context, it will be very tough. And very tough that we will have a randomized trial. I'll be very keen to see randomized trials without ADT
Kumar,
of 800 patients.
There is one group, British Columbia group.
You will, Vivek, you will always have one in Mars.
No, British Columbia group is a big group. We don't read that. See, they have done, I will treat this as high risk disease, and then they've stopped at 1 year. And when it recurs, they have used intermittent ADT.
I agree
and they have done well.
That I agree with you. So my apology for that comment.
That is why I said 1 year is good enough. When it recurs, we will again restart.
Okay. So basically, as sir rightly said, so again, we are not discussing the circulating tumor DNA mutations to stratify this thing. So when that debate will come, so we'll stick to the next abstract. So Daro plus ADT and chemotherapy together. So 4-5 years back, the IGR group, Institute Gustav Rossi, presented their data of abiraterone, steroids and chemotherapy, and now this paper. And it has Amshi has clearly mentioned what is high volume disease versus low volume, high risk, low risk. So are we ready? Another question to medical oncologist. Vivek. So you are using the triplet?
Yeah, sir.
In the practice?
I
Which
think
one?
the triplet is already there for the high volume and high risk disease.
So you are using everything upfront in a
Yes, sir. We are using the triplet. We have started using triplet in eligible patients.
So you are using for all patients?
No, sir. We are selecting
what are the subset of
patients very wisely. Means for triplet, if there is a synchronous metastatic disease, high risk, high volume, then only. If it is a metachronous, then maybe I'll still prefer a doublet agent. But if it's a upfront synchronous metastatic disease having a high volume disease, then maybe, and again, patient factor is also important. How is the patient young and what is the comorbidity? If patient is elderly having a comorbidity, then I will not prefer using a triplet regimen.
So this is very important point, as you mentioned, the comorbidities and patient factors. And we have recently started the geriatric clinic. And this is a disease largely of a geriatric age group. The assessment is very, very important. You have, why the assessment is important? It is not for the overall survival of PFS, it is to reduce the toxicity. And we are talking about a lot of toxicities of ADT. You are trying to add the newer anti-androgens, which are, the fatigue is the most important factor. Docetaxel, again, fatigue is the most important side effect. So whenever we are just looking at the survival data, you have to see whether the patient is fit. Look at the patient factors. Geriatric assessment has to be there. Maybe, sir, one comment from you. Kumar, sir. Geriatric assessment in prostate cancer patients, because we are talking about triplets. We'll take a comment only. We'll not have reactions from the panel.
Bharat is putting me in a spot because we have a geriatric clinic and we send all our patients there. And then you will get, if you use one chemotherapy, 50% toxicity is there, 70% is there. But it is helpful. What we have seen, we just analyze the data. When it goes from geriatric clinic, it goes to individual clinicians. What do? Looks like 40% they do change based on the geriatric clinic assessment. And again, there is an analysis again which has been done that when you reduce the dose based on that or reduce the treatment, what happens to the outcome? And it looks like when you have a problem regarding toxicity, is good to reduce the dose, and that data will be out soon.
So that is why I wanted to have a comment from you. Reduction of the dose, please, one comment only. I have a few more abstract to finish.
No, only one comment which I have. Cognitive functions.
Yes, very important.
That's the most important thing today. I think we have never looked at that. And this is the time for us to look into that.
Yeah, so Not as a geriatric assessment, we have been doing at a spinal level assessing the patients, but now the cognitive function is a part of geriatric, very important. And in the prostate cancer, we have been using since decade, what is the ultimate survival? If the survival is less than 5 years, we have not opted these therapies to our patients. Even we have not opted anything to other patients. That is very, very important, because now the space is crowded and people are jumping to 3 drugs. I know I will use for all patients. It's not for all patients. At spinal level, what we have been doing, we have to do it in a systemic way, and the cognitive function assessment is very, very important, sir. So, financial toxicity, we will not go into that. We assume that everybody have access to everything. Yeah. So, this is the next phase 2 double-blinded placebo-controlled trial, NRG trial of radiotherapy. We have actually discussed, we don't have no debate about not using the ADT. So this is again a 60-year-old male with no comorbidities, operated by robotic surgery, followed by 2 years of adjuvant ADT, followed regularly for 3 years, post-ADT, slow rising PSAs. So in the clinic we get patients with very slow rising PSA, where actually a few of, this is again anecdotal, we have followed them and nothing we have added, and they have done actually well. And that is why all these questions come. So for a slow rising biochemical failure, what are the investigations? Maybe no surgeon can add over here. Only you answer, then we'll go to...
Because we operated upon him, so we would like to evaluate at least once. So PSMA scan, yeah, PSMA
so
PET.
You will do the scan.
Yeah.
And so there are doubtful pelvic nodes, and PSA remaining stable again with the doubtful pelvic nodes. This is actually one of the clinical patients with me, he has been following since last 2 years. With nodes coming in, PSA becomes 1.8 to 2, again then goes back to 1.7, again becomes 1.9, but no symptoms, asymptomatic.
So if the PSA doubling time is less, slowly growing.
But the PSMA scan has been done here.
Yeah, okay. So now I think I will refer to medical and the radiation
Vivek,
people.
quickly, without wasting time, now Vijay and okay, first Vivek and then both Vivek.
So patient is off ADT.
Yeah.
Adjuvant 2 years finished, 3 years off.
No, when the patient had PSA failure, did we start ADT or we did not start ADT?
It's the surgery. 2 years ADT, 3 years asymptomatic period, PSA is slowly increasing.
So when the PSA is rising, did we start ADT or
Observation, we just observe.
So I think we need to start ADT because it's a PSA failure, and then
so it is delayed.
And it's again what we see as a low risk, low volume metastatic disease. So novel hormonal agents, probably enzalutamide plus ADT is what I would say.
Yeah, asymptomatic.
Yeah,
so
I
this
think,
is
sir,
actually happens
in asymptomatic, non-metastatic CRPC, we have evidence of treatment. So, this is metastatic patient, hormone sensitive. So, we will go on to treat with, agents which will cause least symptoms. I think enzalutamide or darolutamide is a perfect, solution Vivek, for this situation.
How do you know he is hormone sensitive?
Because he's off ADT.
No, 2 years they have given. They have given 2 years.
So as per the definition, assume that it is growing and now it becomes castrate resistant because the PSA is rising and you have bone lesions.
But if he's off ADT for 3 years, then he must have a testosterone more than 50. Of course, we'll have to evaluate that.
Mike, okay. Dr. Vivek.
So you said he is asymptomatic.
Asymptomatic, PSA rising, but the speed is slow.
I would get an MRI done, see the volume, what is happening in those places. D3, if it is a big mass there and closer to the cord, I would definitely do a prophylactic radiation. Now SBRT is the name of the game. So SBRT. With the ADT. With ADT.
Dr. Parni?
Start ADT and then assess the lesions.
Because still maybe
on individual
it's a
basis
sensitive disease. Yes.
And do SBRT, yes.
So the last probable case, the 67-year-old male, metastatic castrate resistant, and he has failed on the previous lines of therapy, both oral agents and chemotherapy. And now we have a lot of discussion going on for newer PARP inhibitors, immunotherapy. So how to, Ajay, coming to you. So this patient has already finished, available. Now you have darolutamide available or apalutamide available with us. Access to immunotherapy. Remember, I have mentioned about the family history, not for this patient, but you can add that this patient has a positive family history. And now, so for this patient, I'll tell you, I have done the PSMA scan, and I got a call from my friend that, send the patient for lutetium therapy. Similarly, I have another patient, upfront patient, who has done the PSMA scan. The PSMA scan was, PSMA uptake was very high. patient has not received any systemic therapy, so two different patients. For that patient also, he said PSMA uptake is very high, you send the patient for PSMA therapy. So where do you place the place of PSMA therapy now? Because it is easily available for us.
Sir, at present, based on this, patient has utilized docetaxel and this novel anti-hormonal therapy. So maybe between, I'll keep both the option, either cabazitaxel or lutetium-based therapy. But if there is a bone predominant disease, then I'll prefer lutetium-based therapy, and simultaneously I'll plan for the future therapies also, like HRR testing and MSI testing, so that I'll keep the next line, because in some time this line of therapy will also fail. So, but between the cabazitaxel and this, if bone predominant, I'll prefer lutetium therapy.
Yeah, so this is doable, it is accessible. Again, financial toxicity is one of the reasons why we choose chemotherapy. We sometimes do it, but we'll not. Now there are so many agents available. So, see here. Yeah, then definitely that is the doable option, challenging with any of the agents. So this particular trial has not shown the overall survival advantage. Maybe no crossover is the reason, but there is a good benefit in terms of response rates and PFS, both the radiological as well as the biochemical PFS. So now this space is getting again crowded post chemotherapy, post AI. You have immunotherapy, lutetium, you have this PSMA therapy and PARP inhibitors. But again, these newer trials, TALAPRO, where they tried first-line talazoparib with enzalutamide for all comers. So quickly, I'll short it. In the trial, they have come down to the benefit to only BRCA patients. This is another trial, PROPEL trial, and 2 days back, the FDA granted permission to this combination, and this combination is abiraterone and olaparib, and talazo is talazoparib with enzalutamide. So there was no overall survival benefit in statistically significant, but yes, based on the PFS and OS benefit in BRCA1, BRCA2, not in all HRR mutation. Forget about those who are not HRR. It is restricted to the HRR initially, and the update showed, which is presented in this year's GU ASCO, that only those patients who are BRCA1, BRCA2 mutated got benefit, and FDA has given approval 2 days back for this combination strictly for those patients who are BRCA1, BRCA2 positive. So now we have picture clear with the olaparib, and we have this trial. So Vivek, we have a patient who has progressed on all the therapies. How do you go about this combination? And then Ajay.
So again, sir, this combination is for upfront rather than when patient has failed multiple lines.
Yes.
And for combination treatment, just as I stated earlier in my presentation, that for a molecularly unselected group of patients, we would not want to start them on drugs like PARP inhibitors or immunotherapy, because they are costly, as well as they have significant toxicities. So this combination treatment, I agree, for a selected subgroup of BRCA1, BRCA2 mutant patient.
So will you use upfront, or will keep the PARP inhibitor in sequence?
What I believe is, sir, is that the PARP inhibitors, we need to bring them early on into the management in the selected subgroups of BRCA1 and BRCA2, whether it is breast cancer, whether it is ovarian cancer, whether it is prostate cancer. So if it is BRCA1, BRCA2 positive, I would want to bring in the PARP inhibitor early rather than wait for later, because I feel later on docetaxel or abiraterone or they may give you the good advantages, but later on when the disease has progressed, the PARP won't give you that advantage. I need to bring it early if we want to take out the best advantage of it.
So the answer from the 2 trial is very clear. You have to
ask him one question. Would you give it with abiraterone, say, or alone?
If I use upfront, it is going to be with abiraterone.
So this is more mature trial, because the Talazo trial, TALAPRO 2 trial is still not mature at to this level, and this approval is based on clearly the data in the BRCA positive subset, where the hazard for radiological PFS is 0.23 and overall survival hazard ratio is 0.29. So number looks good. So as Vivek rightly said, somebody who is BRCA positive, why not to use upfront when there is more mature data? So this is one more trial where this is not a part of, in the interest of time. So Ajay, so when a metastatic prostate cancer patient comes to you, would you recommend germline testing upfront on day 1 of consultation?
Yes, sir. Now almost all patients who are coming as a metastatic, we are trying to do a genetics testing and counseling in all patients.
Yeah, what percentage of the patients, anybody can take this question, Dr. Vivek, and
Maybe, no.
anybody from the crowd, what percentage of patients are like, but we have not been doing regularly for all patients, but now there is a data, we have to consider.
The problem is that we go for testing and later on when they are already CRPC and having exhausted 3-4 lines, and by that time a lot of many of the patients, they don't have the blocks and the blocks are also exhausted, tissue is exhausted.
This is germline testing,
Yeah. So, but I think the germline testing now we are doing for a significant number of our patients. I mean, almost 70% probably in metastatic prostate cancer we are doing germline.
Okay, and what is, no, anybody has used PARP inhibitor for metastatic prostate cancer, quickly they can add their experience and we'll move on to the next.
Sir, we have used in metastatic set, but after the exhausting all the therapies who came as a BRCA positive, but only that the tolerance is very poor and
Yes.
the outcome is also not very good in the...
So post chemotherapy, post newer androgen patients are already anemic, and then the main side effect of the PARP inhibitor is anemia. And anyways,
when you use it later on, that is why it is very difficult to
totally
use.
agree with you. Yeah, totally agree with you. So we should bring the PARP inhibitors upfront. Now quickly going through your trial, Vivek, no, that this stopped because of futility. But again, you clearly mentioned the benefit was in the BRCA group. So why to use immunotherapy? Use only PARP inhibitor over there.
I totally agree that using the trial design was not correct, and I don't think that there would be any advantage of adding immunotherapy to BRCA positive patients. Probably they need to do the study. They should have had an only olaparib arm to really prove that pembrolizumab was adding on. So in the unselected group, probably never add immunotherapy, even only with when they have mutations TMB greater than 10 or MSI high.
So message is very clear. When a metastatic prostate cancer comes to you, you have to counsel them for genetic counseling. Don't advise them BRCA testing. Send them to the counselor. It is the counselor's job to counsel, and then with all information in mind, the patient has to decide about the genetic testing, because we have molecules available which patients are getting benefit. Geriatric assessment is very, very important. Now the showstopper of the today's meeting is CAR-T. Nandini, Dr. Nandini is there. She has presented the data. Now everybody is aware about the CAR-T. These are genetically engineered, the immune cells which are re-injected in the patients, and they look after the refractory disease. It has already achieved success in hematological malignancy like ALL and lymphomas. I have recently met a patient who has undergone CAR-T therapy 4 years back. So it has changed the game in leukemias and lymphomas. So we are seeing in solid tumors that this could. What is the idea behind it? The immune cell has to have a target, single target. Now what happens if you target at one target is achieved? Again, the cells are very smart enough. But in leukemia, CD19 is the target. In myeloma also now we have genetically engineered CARs coming from abroad. We don't have one person from the IIT has designed this CAR-T vector, and 15 patients data is already out. This is first India-made indigenous CAR-T cell, and the data looks promising. They have already moved into phase 2, which is designed, I think. The adult patient is also recruited. Initial data was from the pediatric. So this is the background of the indigenous CAR-T from India. We have a lot many centers abroad which are doing CAR-T for hematological malignancy. In solid tumors, prostate is one organ where a lot of data is coming up in the phase 1 going into phase 2. So this is the data presented of phase 1. So it is feasible. The trial was stopped because of the one death. Obviously, as the numbers are very small, you have to take that step. The data will come out with the updated results, and maybe the CAR-T will move into phase 2. So Vivek, any comment from your end? And Ajay, about CAR-T in solid tumors?
I think, the class of solid tumors who really have good response to immunotherapy, probably those are those classes, which will have a good future of CAR-T. And just as you said that solid tumors, they are having multiple antigens, and they have multiple mutations. The mutation burden is usually high, and that is the reason why the tumor is able to evade, a single line of, and so targeting a single antigen, probably CAR-T. I am looking at dual CAR-T and a triplet CAR-T, sort of concept that might come up to tackle solid tumors. We have dual CAR-Ts already in hematological malignancies. So those kind of approaches probably are going to come in future.
So that is the future. I probably know these tumor cells are becoming smarter, so we have to learn how to be one step ahead, and that is where immunity. So immunotherapies are evolved in that way only. We used to kill the tumors with chemotherapy, but in spite of getting the excellent responses CR on the scan, we used to be worried, kab wapas aayega. This immunotherapy is like what we use monoclonal antibody checkpoint inhibitors, then are bispecific, then somebody has tried dendritic cell therapy also. This is, I think, very promising. We are seeing success. Success is there in hematological, and hopefully in solid tumor also we see cars coming up, and go-karting happens with the oncological patients, getting cure after multiple lines of therapy. That is what happens in prostate cancer. You use multiple lines of therapy and there is no therapy, and probably this is it. Because we tried adding immunotherapy, there is not many success. The MSI high percentage is very short, where you get excellent responses. In rectum now, the radiation and probably surgery is out in that 3% of patients who are getting MSI high. But in prostate, so far I have not got any patients who is MSI high. Probably, this is what the cellular therapy is the key answer for majority of most of the solid tumors. And this is the future. We have to enroll our patients in the clinical research trials. Fortunately, we as an oncologist community coming together on various platforms, and we should discuss ongoing clinical trials with the patients. Enrolling on the clinical trial is something which NCCN or any other guideline always recommends. So do look around yourself if there are clinical trials and your patient is fit. We must enroll those patients on the clinical trial. Thank you all my panelists to having this wonderful discussion.